call to order our March 26th meeting of the Board of Health. It is 12:35 p.m. Currently absent are Commissioner Brooks, Maureen Rosette, and Patricia Keenholz. Patricia may join in progress. I'm also told we do not have any written comment and no one is signed up to speak. Is there anybody intending to speak? Not seeing anything there. Okay, then we will move forward to board reports. I really don't have anything in particular for a chair's report, so we will save some time and move forward to the committee reports. I know we don't have Commissioner Brooks on the Finance Committee. Is there somebody who can provide an update there? Mr. Waldron?
Yes, Patricia and Chair Brooks and myself, we all met on Monday, had our Budget and Finance Committee meeting, and reviewed items that you'll see on the agenda today, mostly on the consent agenda. One of those is a contract with Dr. Sam Artsis. He's our backup for Dr. V when Dr. V is not available as our, so we have a contract in there that we looked over, and there's a Precision Diagnostics does urine analysis for the treatment center. We actually have a contract to consider where the dollar amount went down, which is not usually what you see. So, and then we got some budget updates, which I know Kim, as you know, although some of the cuts were restored at the state level, there was still this issue of a fund that was supposed to fund the local public health districts and the state across the country across the state that did not get resolved. The problem with the funding of the vapor and nicotine taxes being put towards public health. So there is going to be some impact to local health jurisdictions. So we'll get an update from Kim on that today. And it's not resolved yet, but something that we're going to have to plan for. So we discussed that. And then the other contract is just an interlocal agreement with Spokane Valley. This is the, here at the health district, the data center is working with the Spokane Valley on data specific to their city related to opioids, and they're helping them create a dashboard, and it's just an extension of the contract. So those were the updates.
Very good. Yeah, I definitely look forward to our discussion on some of the finance things. We are going to have some impacts we're going to have to work through. And I'll just recognize that Patricia Keenholz has joined us in progress here. With that, let's see, Executive Committee, we really just went over this agenda, the items that are here, talked about some of the same items that you just mentioned in the Budget Committee, as well as just some logistical discussions around the transition with the upcoming administrative officer. And so with that, there's no policy committee update, so we'll move to consent. Is there anything anybody wants to take or needs to take separately? If not, I would entertain a motion to adopt the consent agenda as presented.
Move approval of the consent agenda as presented, item number 5 on our agenda.
I'll second the motion.
Motion and a second. Is there any discussion? Seeing, hearing none, all in favor, please say aye.
Aye.
Aye. Any opposed?
Aye.
Or abstaining?
Aye.
Okay. Well, with that, next up is our executive session. So I'll turn it over to Michelle to read us in.
Thank you. The board will go into executive session for the purpose of litigation, potential litigation, pursuant to RCW 4231.10.1I. Present will be the board members, legal counsel, Ray Byrne, and Kim Kramar's co-administrative officers. And I anticipate, I think, 20 minutes.
So 20 minutes from now, we'll give ourselves about a minute to transition here. So about 101. Okay, well, we are back from our executive session. We did not have to extend. The current time is 1:02 p.m. With that, I would like to jump to 7B and entertain any motion related to 7B, if anybody has. And I can go ahead, Commissioner Waldron.
Okay, Mr. Chair, I'd like to make a motion to approve items 7A
B.
and 7B. Oh, sorry, we're not at 7A yet. We'll start with 7B.
We're gonna do
Got
7B.
it, got it, sorry. So I'd like to make a motion to approve the settlement agreement as presented contingent on an agreed upon letter of reference.
Thank you. Is there a second?
Second.
Great. Motion and a second. Is there any discussion? I'm not seeing any. All in favor of the motion as stated, please say aye.
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 Any opposed or abstaining? Okay, that motion carries. All right. Now we will go back to 7A, and I will just say there is a lot of interest in finance and less so in policy. So I will just say the names that I have are folks who have reached out proactively and said they want to be assigned to a particular committee. And I would certainly, in my mind, give some deference to folks who are already on those committees. But Commissioner Jordan and Patricia Keenholz had both requested to be on the Finance Committee. And then Maureen had said she had no preference and would just be open to being assigned. And so I don't know where Commissioner Brooks is in her desire. I assume she would want to remain on finance, but I have not heard that from her. And then I'm not sure, Commissioner Waldron, where you're at.
Yes, if Commissioner Jordan wants to be on the finance, I think that would be good as the vice chair as newer to the board. So I'd be happy to switch to the policy committee.
Okay, that'd be great. And why don't we'll put Maureen there, and then Dr. Blakowski-May, did you want to remain on policy or did you have a preference?
I had an interest in being on the finance committee, but it's whatever works best. I've been on the policy committee now
Yeah.
for the prior term, and I would be interested in being on the finance committee.
Okay. Let's see.
I'm willing to go on policy.
Policy?
That way it frees us, that way there's more room on the budget committee if folks
Great.
want that, so.
Derek, are you okay to be on policy?
Yeah,
Great.
yeah.
Okay. So, and then Liz, I don't know if you have a preference or a desire?
Yeah, I wanted to do policy and education committee.
Okay. All right. So what I've got right now for policy is Commissioner Waldriff, Maureen Rosette, Commissioner Kearns, Derek Baziotis, and Liz Henry, and that's 5, and we can have up to 5, correct? Okay. And then on finance, I have Commissioner Jordan, Patricia Keenholz, Commissioner Brooks, Dr. Blakowski, and myself. And that would be 5 and 5, correct? Okay. All right. And then the executive committee is set. And okay, so with that, and were you able to jot those down, or I can give you a list. I've got it written down here. But if that's acceptable to everybody, I guess I would look for a motion to adopt that slate for the policy and the budget and finance committees.
I would move to adopt the slates for policy and finance committees as described.
Okay, is there a second?
Second.
Thank you. Motion and a second. Is there any discussion? Seeing none, okay. All in favor of approving the motion, please say aye.
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 Any opposed, abstaining? Okay, we got those set. Great.
Michael,
Yes.
can you just
Want me to
tell me who the
restate?
policy and
Yeah.
education committee was
So,
again?
yeah, so the Finance Committee, I have Commissioner Jordan, Patricia Keenholz, Commissioner Brooks, I have Dr. Blakowski-May, and I have myself. And on policy, I have Commissioner Waldriff, I have Maureen Rosette, Commissioner Kearns, I've got Derek Baziotis, and I've got Liz Henry. Are the chairs determined by the board, or is that within the committees?
That's typically within the committees,
Okay.
but it can be done here in the meeting if someone wants to step forward as the chair.
Okay. Is there anybody particularly looking to chair? We'll start with policy. Not seeing any. So I guess we can let you guys hash it out at your, if there's when the first meeting occurs. Okay. And then
Hash it out. We'll hash it out.
yeah, Commissioner
Who
Brooks.
wants to be in charge of one more meeting?
Commissioner Brooks has been chair of finance. I presume she would like to continue. I have no issues with her continuing in that capacity. And so I'd be fine establishing that. Is there any concerns or opposition to that? Not seeing any? Okay, then I don't
I
think we
say
need a
because
motion.
she's. this
Commissioner Jordan?
meeting- Oh, can you hear me? I was gonna say because she's not at this meeting, we should just go ahead and tell her to be the chair.
Very, right on, exactly right. Very
I
good.
believe that is Robert's Rules of Order.
That's true, that is true. That's the
Maybe,
default.
maybe,
Right.
yeah.
Okay, do we think we need a motion to affirm those chair positions, or are we okay? Okay, all right. Well, with that, then, we will move along to our reports. Administrative Officer, Ray.
So I just have two real quick things. One, just to announce and reaffirm that our new administrative officer will be joining us on April 13th. So we're all excited about that, anxious to move forward and get back to business. So second thing is that we are going to be doing, and Ann had sent this notice out to the board. We've got the state auditor's office that will be coming in to do a cybersecurity audit for us. This is a voluntary thing. It's not mandatory. They offer a series of audits, which we have reached out to them. So the entrance conference for that will be coming up on April 13th as well at 8:30 to 9:30. So if you are interested in participating in that, if you could let Ann know, we want to be careful that we don't have a quorum of the board. So, and then after the audit is concluded, then we will have an exit conference. And that's it.
Let's see, next up is Finance.
Good afternoon. In your packet, you have the February 26 financials, as well as I have them on the screen here. So we are going through the month of February, which is about 16% of the annual budget. And so overall, we have 9.67 in our expenses. So we're coming in lower. Our salaries and benefits are just under 16%. And our supplies and services are 9% and 2%. So overall, supplies at 9.67%. Funding overall, we have for the month of February, 1,187,729. We have not invoiced for the state grants, and we anticipate additional funding coming in for that. So we're calculating those numbers right now. So overall, for the month of February, it looks like we have a deficit of $1.6 million, but collectively between January and February, we're still in a surplus from January through February, and that's primarily because of the FPHS funding, Foundational Public Health Services funding that we receive every January and July. So those funds have been advanced to us. We also have the first quarter of the county assessment on our books. So advanced revenue in this case. And the lower part with reserves on the next slide here, our goal is to have 20% of our reserves, 20% of our budget as a reserve, and we're actually at 25% because we still have those advance payments of funding. The reserve calculation committed is staying at 1.5 million, so that's consistent. But we also have the assigned reserve categories, and so we're finalizing our 2025 numbers right now. And so next month I will be able to show a reflection of items that have moved from assigned back into unassigned and show you a picture of what we have earmarked for the 2026 year regarding assigned. And overall, our total reserves is 21 million.
And then this next month will be subject to audit. Our auditors will start coming. We prepare our annual report now through the end of May. We have to file with the state auditor's office by May 30th. And then usually they start auditing June 1st. They come pretty quickly. And so everything will be subject to their review. But if there's anything material, we'll certainly let you know about that change. And then the other item as far as financial, giving you an update on FPHS funding, which is kind of the hot topic right now. The governor still has not signed the budget. We've been waiting and watching for that. However, this morning we did have a Wasalfo executive leadership meeting to discuss the FPHS funding that starts the funding period from July of 26 through June of 27. So that's considered federal or fiscal year 27. And there's been a lot of discussion around the funding formula that's been used for dispersing FPHS dollars. The system includes local health jurisdictions, state board of health, the tribes, and what's my fourth one? Oh, thank you. Department of Health. Can't forget Department of Health. So the system receives the FPHS funding. So the allocation formula that we're discussing is how we would allocate within the FPH system just for the LHJs. So you've been hearing the $21 million reduction that is noted and expected July 1. That is across the system. We don't know how much DOH can absorb and how that will be spread and then amongst LHJ. So we do have a formula. The vote today was to explore further on the formula, but we have some nuances that we need to adjust. We don't want to see necessarily increases to some LHJs when there's decreases across the board. So there's a few calculations that need modification. We still have January through June of 2026 that we're working through, and the number keeps changing slightly. It was 3.9 million shortfall. We're looking across the full system for underspend and identifying, and so we've been able to bring that down to just under 2 million. And then there's been a further call out to all participants in the system to look for underspend. Maybe there's people that went on a leave that perhaps was like paid family medical leave, which isn't on our books then. You could have some savings there. So really looking and tightening the budgets to see if we can have everybody come together and have some unspent returned. Once that's calculated, then whatever's remaining that has to fill that gap will be distributed across the system, or across LHJs, excuse me, that's just LHJ specific. So we are anticipating, even with an underspend across the system, we will have a reduction as well. So more to come, still a bit volatile. Any questions on FPHS? Yes, Derek.
You said the state grants none of them got sent out for February. Is that 8,324? Is that a rollover from January?
No, that's actually how much we did calculate in time for this report.
Okay.
So what happens, most of our grants, other than the FPHS funding and county funding, we have to bill for them first and get reimbursed. So once I close out the month of February, we take the month of March to calculate what the billing is and get them entered as accounts receivable. So it's timing, which is why it's really important to have healthy reserves to cover those costs. It can take 30 to 60 days for reimbursement. So we were able to, some small ones, we knew what the calculation was. Usually they're just payroll specific, and once payroll's paid, then we know immediately what we can bill for that. Yes, good question.
Other questions, Commissioner?
Kim, on the budget committee call, you did mention that you and Ray have been trying to kind of anticipate that we might have a shortfall from what was expected from the state. So you're just looking at areas of the budget that we could potentially, if there's someone that leaves, just leave the position unfilled for a little while we're in this time of uncertainty. Obviously, you can't do that with every position. We have some that we have to bill to grants. But how are you kind of managing that over the next quarter, I guess?
Well, we've definitely, and we've had this practice for quite some time, but when there's attrition for any reason in a program, we do ask the program to evaluate and do a business case analysis as far as Is it a one-for-one replacement? Is there a shift in the program? Can we do things a little bit differently? To reevaluate if that's a needed position. So through regular attrition, we're doing that. We've identified some cost savings in realigning a couple programs together when we've had some recent retirements, which has helped. And all of this in anticipation of what we've been hearing with FPHS. And then, of course, with our indirect programs, we have to follow suit. If we lose funding in programs, we need reductions in the indirects. So we're doing the same thing with that. How can we consolidate some of those programs when there's gaps? And we'll be developing our 2027 budget. We start that process right after 4th of July. So we'll start having those tools available to us and hopefully more information on funding to really start developing and making decisions in 26 with that as well.
Is there a deadline by which the 21 million that won't be available for the foundational public health funding because of this vapor fund that did not get funded? Is there a deadline by which all these jurisdictions and the state need to make a decision about what the cut will actually be?
Yes, the goal is very early May to make that decision, and so that everyone will know what those reductions look like
Okay.
that are effective.
So we have
July
another
1.
month or so to work through and
Mhm.
look at different alternatives and, okay.
Yeah, really, I mean, that's priority certainly because that's a huge impact, but also the priority is what can we find in the underspend or in unspent or underspend to fill the gap before June of 26. So that's also a high priority for us.
Thank you.
And we already have those funds, so we're expected to return them, which is the unfortunate. Thank you.
Anything else for Kim? Okay, with that, thank you, Kim. Legislative, I don't think we have any particular legislative update, correct? All right, then we'll move on to Dr. Velasquez, Health Officer.
So good afternoon, everyone. Before I go to my report, I'm going to go back to Commissioner Waldrop's question and give her an example if I can. I'm going to give you an example if I can of what we just talked about. So as we were looking at the budget and the challenges, disease prevention and response, DPR, Mark is here from DPR, we actually looked at a potential retirement in at the management level. And actually have realigned the organization as of April the 1st. Instead of having 4 program managers, we'll have 3 by rebalancing and retooling the division. We also have a resignation based on someone moving out of the country, basically. And we have chosen not to backfill that position. And again, rebalance the workload. And the reason I bring that up is because that's kind of like the 3rd time we've done that, at least in DPR. So we have actually very judiciously being realigning, combining, and decreasing not only staff, but also managers. And I just want to give you an example of what we've been doing proactively in anticipation of the coming challenges. And I know everybody else is working on that, but that's an example that's already executed that will be effective April the 1st. So just to give you some background. Okay, so with that, I'm going to move on to my report, and I'm going to move a little bit quickly because I know we have a lot of presentations that do need some time. I'm going to talk a couple of things that are in everybody's mind right now, like measles, and why did we extend our RSV season a little bit. But before we move into that, actually April, in addition to being National Public Health, and Kelly's going to talk about that, so I'm going to steal her thunder, it is also the National Interprofessional Healthcare Month, which is something that's a whole proclamation from the National Interprofessional Healthcare Agency. And the reason why I bring that up is because this brings to light the collaboration between many to actually deliver on healthcare, and that includes public health. We're part of that category. But the main reason why I bring that up is because in Spokane, actually, we're very fortunate to have a very, very good example of interprofessional collaboration, everything from education to delivery of services, which is what makes this region in healthcare so attractive. And I just want to say thank you to all of our partners out there, because it's not just about doctors or nurses, there's therapists, there's pharmacists, there's radiologists, there's MAs and PAs, there's a whole team that allows us to have the great healthcare that we have. So I just wanted to call that out because we do work very closely with our partners, and many times we just hear about some areas like, doctors and nurses. We are very important, but there's 7 to 9 other professionals for every provider or every licensed provider that is there to really be able to deliver the services, and public health fits in the category of interprofessional professions. So anyway, just a tidbit of information, something that we haven't really looked at before. So let's talk about measles, which I'm sure is a hot topic. And after I finish that, I'm going to make it even hotter a little bit. But just to give you a little bit of perspective, 2026 started with a pretty high takeoff, as you can tell, compared to 2025, which basically tells us that what we saw in 2025 is not decreasing, is actually somewhat accelerating. And this is at a national level. Previous years at the bottom which have been somewhat quiet. This is the spread around the country. As you can tell, is fairly distributed. Many imported cases, meaning someone got exposed somewhere else, but also many cases that are native or from the location. And sometimes we have the reason for it, sometimes we don't, because it's really hard to track some of this. But as you can tell, is spread around the country. The reason why I bring this map up and the reason why I show you now the states and the counties with particularly those that have the higher concentration is because spring break is coming for a lot of people over the next couple of weeks. So if you're going to be out and about and traveling and moving to other parts of the country, just make sure that you have checked with your pediatrician or your primary care provider in terms of potential protection for yourselves or your family, as we all, I'm not traveling, but a lot of other people travel. Just a heads up, that is in high concentrations in many parts of the country, including some of the areas that we tend to go because they're warm and nice and sunshine and so on and so forth. So that is the country. This is the state of Washington. And as you can tell, we actually have contributed about 28 cases to the total count around the country. Most of them focus on Snohomish County, which is about like half of them. As you look at other areas like Clark County and others, which are a lot smaller than we are, sometimes people try to compare. So why don't you do this, or why don't you do this clinic? But risk level is a little bit different for us. And actually, we have such an assertive response that, and the resources that other counties may not have. So how we respond is actually the ideal model, and we're going to continue doing that as we go forward. Now, what's going to happen? All I can tell you is with that uptick, we're probably going to see more, which brings me to what I wanted to share with you before last night, because as of last night, it changed a little bit, which is we did have an exposure, and we did release that information. The exposure was between the 14th and the 15th of March, from a patient not from Spokane County, but from Kootenai County that happened to be here for care, because we are regional referral for many areas around us. And this is where we saw the exposures. We're running out the incubation periods until like the first week in April. The team has contacted all of those that are involved. And I do want to say thank you particularly to our friends at Providence, because they were not only very proactive, but have worked very collaboratively with us. And we were able to mount a very assertive response that allows us to really kind of close the loops around any of the potential exposures. Now, that was as of yesterday. Last night, we were made aware that there is another exposure from another patient who is from Spokane County. We don't have all of the details, but we do know that there are at least 8 or 9 sites in which exposure may have occurred. So we're preparing that information to be released. Actually, there's 9 of them between Wednesday, March 11th to Wednesday, March the 18th. The patient was recently diagnosed basically yesterday. So more to come on that. We will mount the same all hands on deck response that we've done before. This is a little bit more concerning just because the many places where the patient was, and these are, restaurant stores, entertainment places, so that you tend to have lots of people in it. and it becomes a little bit more difficult to trace and track everyone. When we work with Providence, we know exactly who was where, and that's usually a lot easier to track when you're working with open spaces. It becomes a little bit more complicated. So more to come on that. Press release is being finalized. We wanted to confirm a couple of dates just to make sure we have that. That will be coming out. That's all I can probably tell you as of right now. But just for you to be aware that we're already have been engaged as of last night, and we'll continue moving forward as we typically do, and we'll keep you posted on that. So with that, I want to talk a little bit about RSV. And if you look at the colors, and I know it's hard to trace the colors, but if you look at this purplish over here, grape color, that's actually the 25-26 season. And you can tell that it started a little bit later than it typically does, which basically pushes the projected end of it by at least another month. So as a result of that, and the fact that we still have, this moves to, that we still have higher than threshold activity, particularly in emergency departments, we, in collaboration with our healthcare partners, basically, this as the typical age groups, extended the RSV season by one more month. That allows us then to continue the resources and allows our healthcare providers to be on top of whether we're talking about preemptive measures or counseling. So just for you to know that went out on the 17th, and that allows us to extend, monoclonal antibody administration and a few other things like that. So hopefully that will settle. Although if you look at the kind of the takeoff, it's a little bit interesting, just the way that it really didn't take off for quite some time. So we may need to modify that, hopefully not, but just to keep you apprised if you hear about that. So with that, I want to talk a little bit about what the team has been doing, because there's a lot of activity. The team, as you know, one of the things we've been doing is trying to encourage our team to participate, engage in presentations, posters, articles, et cetera, et cetera, et cetera. We do have a fair amount of activity there. So this is one that is being presented at the upcoming Nature Preparedness Summit. Very long title, but what it basically means is we develop a lot of tools to help us manage risk areas such as wildfire smoke preparedness and activity. So our friend Rebecca is going to be presenting that, was accepted for publication. So I think that is great. Kudos to her and the team upstairs at Preparedness. Then we also have a collaboration. Actually, this is one person, but then we have a collaboration with the same person from our EPI area, which will be presenting that vector-borne disease. And actually, it's kind of an interesting area that we do have some folks that are becoming known experts around the state in vector propagated disease. This being one of them, Aaron, who just published, this being published in the County Medical Society Journal, which will come out in the next month or so, about Lyme disease, something that we sometimes forget that although we're not in the Northeast, you can still see it. And she wrote an amazing review for our colleagues. Those are typically physicians and PAs who are members of the association. So we try to have in every issue something that we provide guidance and or information about. And then last but not least, we have moved wastewater beyond what used to be COVID at the beginning. We're moving into a number of other areas in which wastewater may be useful. And this is actually a presentation that is going to be in the ESNT Water Journal. It's a very long name for the journal, but focuses on that by Lisa, who was the previous author, one of our epidemiologists, and Kristen from Disease Prevention and Response on here, who have been working on the model of sexually transmitted infections, tracking those through wastewater. More to come on that. We're trying to do a couple of things, which is using wastewater, which is already there, to our advantage in areas, and there's many other applications. We've looked at a few other ones where the science is still, we're still working through the science, but there are a few where we can, with some confidence, start to look at and make some, at least, predictions on what happens. So this is just in the last month or so. So I wanted to bring those up because these folks work really hard to try to share information. So all of these are national presentations that our folks are going to be at. And that brings up a lot of awareness about the skill set in this organization. And like I said, many of our folks are seen already as experts around the country in various areas in which we may not think about, but that are important to public health. So I'm going to stop here and see if you have any questions.
Any questions, Commissioner Kearns?
What's the timeline for the list of locations for the measles exposure? When will that be released
Today.
to the public? Oh, today.
Oh, yeah. It's already being worked on. There's a draft of it. We're just finalizing one detail and to make sure that we have one time, but it will be released already. I'm not reading it here just because I'm waiting for the press release to make sure everything is there, but it will be released probably fairly shortly. Yeah. Good question.
Patricia?
Yes, ma'am.
I'm looking at the proclamation on page 3
Yeah.
of your presentation. And when I came in, I was thinking about asking you about rare diseases. And so I looked up when Rare Disease Month was. So I was wondering, I see here it says the National Academies of Practice proclaim this is National Interprofessional Healthcare Month. But I'm wondering how we follow these different things because there are a variety of different sources for what determines a national
Right.
interest, and so I'm wondering how you choose, or how do we know what month is
Sure.
for what thing, or if there are multiple things in a month, how do we pay attention to that?
Yeah, and that's so I make an executive decision. I'll tell you why. So if you look at every month, there are probably 30 different celebrations on a variety of topics. Like April has a whole bunch of them. And as I mentioned, National Public Health is one of those. But as I was looking at the list of areas that are being highlighted, there are a lot of areas that we have highlighted, a number of other venues, including this meeting. But we never really say thank you to all of that broad team that allows us to have the high level of healthcare that we have. Many times we don't think about it. And the reason why that was resonating in my mind is going back for the last 12 years that I've been working with our higher education partners here, and the significant effort in really enhance all levels of professional activity in the health sciences. Not just doctors, nurses, but there's all 13 other levels that need to be enhanced. And if you look at the programs that are being offered, we're very lucky to have significant programmatic offerings for everything from nursing to techs and everything in between, which is not that common for a community our size. We just happen to be fortunate in the density of higher education and the fact that higher education has focused on health and life sciences, which a lot of other communities not necessarily have or don't have the skill set. So I looked at everything that is happening, and then I tried to highlight something that maybe A, requires a little bit of attention, and B, allows me to say something good about our region. Because we hear a lot of we may not have this, we may not have that, but in comparison to any other community our size, we really have a lot. And we have to be grateful for that. And it's not accidental, it's very intentional. All of our higher education institutional healthcare partners, business leaders have really come behind these initiatives, which is the reason why we have this large cadre of professionals that other communities don't necessarily have. So I'm glad you asked that, because it's one of my, I decided, it's an executive decision. And I agree with you, every month we could be talking about 30 different things. So I always try to highlight one that is relevant to us. Great question, thank you.
Dr. Velasquez, on the last one, the STD research, is the wastewater testing itself being done by a third party, or is that being done by the health district?
Do you remember the details of that, Mark? Yeah.
Sorry about that, Madison. Apologies to the people online. All of that is done at the Washington State Public Health Lab.
Okay. And in this case, was it strictly to look at the STDs, or was there other things looked at as well?
It was to look at the STDs to see if the assays that the State Public Health Lab were considering would be accurate for looking at those STDs in wastewater. So it was more of a feasibility study, and not necessarily something that they were looking at implementing right now, but just seeing if that's a possibility in the future.
Okay. Well, very good. Look forward to seeing the results. Commissioner Kearns?
If I could piggyback on that, which wastewater treatment plant did you use for your samples? Did you use both? Did you the
We
city's
used both.
Riverside or the county's out by the fairgrounds?
Both of them.
Both? Okay.
Yeah.
All right. Thank
Yep.
you.
Interesting. That'll be interesting. Okay. Anything else for Dr. Velasquez? Seeing nothing?
Thank you.
Thank you, Dr. V. Appreciate it. Okay, we've got 3 presentations coming up here. So we will start with Misty, Treatment Services Quarterly Report.
Good afternoon. I want to start off by letting you know that I know typically when we present, we get right into the data points of the treatment services numbers and data. However, today what we're going to do is we're going to start off with just some information of some things that we've been doing, and then we'll get into those data pieces and informational pieces regarding the expansion, and then the plans moving forward with that. So to start that off, I just wanted to bring this up and show that this is actually our treatment services division as of this last November. This is our entirety of our team. And to take the next piece of this, April Pinkney, our associate director, she's going to discuss our Voice of the Customer satisfaction survey.
Thank you. So federal guidelines require all OTPs maintain current quality assurance and quality control plans, including reviews of program policies and assessment of patient outcomes. Sorry, a little nervous. One of the tools that we use is the Voice of the Customer survey. This survey we presented to all of our individuals. It's an anonymous survey, and all the responses were sent through the data center for compilation. So as you'll notice, the first graph there, that is respondents, the level of satisfaction with each of the disciplines. The blue and the green represent very satisfied and satisfied. So most of our responses were very satisfied or satisfied. The graph below that is the satisfaction of the ability for their dose to manage the withdrawal symptom. So each of the colors represents the length of time on the program. And again, most of the individuals reported being extremely satisfied with their dose. The graph on the bottom to the right, that is the respondents' time on the program. So of the 308 individuals who responded, there's a representation of each of the length of time, with 109 people being on the program for 5+ years. So a good response for that. We also provided some client feedback there. We grouped them into satisfied and then some of the dissatisfied comments. We had a large response. A lot of individuals report being very grateful for the program, being satisfied with the care and the considerations that are given. And then some of the dissatisfaction is being switched from counselors, financial responsibilities, and a lot of the rules and regulations that they are required to follow. The responses this year, we had a 92.5% increase from last year's responses. So our clinical assistants did a great job on bringing those in. And that is that. Is there any question?
Commissioner Waldron?
Well, this is great information. Thanks for sharing. So when you get some of the feedback, do you look at that and go, could we do that better? I was just thinking about the one individual that said they have to call and make a payment. Like, are you thinking about, is there an easier way to collect payments from from the clients?
Yes. So all of our managers receive this information and we'll work with the individual disciplines to identify areas that they could improve on or we can improve on, and then also just looking at the successes that we've had.
Could you, I'm just curious, so and obviously still above average, it looks like, but mental health counseling, individual and group, are kind of a lot lower than a lot of the others, including counseling staff itself. And I'm just curious, do you know what the issue is there?
For the mental health, I would say there's less of our individuals are enrolled in mental health services. And then the availability of the mental health services is lower because we have one clinician currently. I'm only assuming
Okay. I
that
gotcha.
that could be that.
And then one of the comments over here says, some of the rules and policies are unnecessary, make life harder. Are they just referring to the having to come in every day, or is there other things?
That's one of them. Yes, is coming every day. Carries for demonstrating stability to get carries, things like that, I think cause some frustration initially.
Gotcha. Patricia?
The one that concerned me was the last one on common themes, where it says I work full-time, so I am not eligible for any financial assistance, but that it's a cost burden for the person. And I'm wondering if that seems like a gap that could be addressed, or are you trying to address that? Or are there barriers to trying to assist people who are maybe moderate income, but it's still really difficult for them to pay?
Yeah, so our financial team has patient service representatives that works with individuals to figure out, is there better insurance coverage that they could get maybe for next year. There's then a grant that some people qualify for. So they work really well with our individuals to try to figure out, overcoming those barriers for them.
Is that something that you ask the people when they come in, or how is it that you survey that information from them, or how do you find out that they're having trouble?
So we always run their insurance eligibility at the time of intake and then monthly. So if they lose their insurance, then obviously we're connecting them with a patient service representative. And oftentimes they gain employment and after they've been on the program for some time, and then they no longer qualify for assistance. And so they, again, will meet with our patient service representatives to see if there's something that we can do to support them. But it is a gap. It is an issue.
Is there a sliding scale that we offer for folks who are either not on insurance or, paying private essentially?
Yes, and I can't speak to that as well. It's kind of.
So yes, we do have a sliding fee. However, those individuals that do not have insurance coverage, that's what a lot of our patient services representatives do. They actually meet with those individuals that do not have coverage in place already, and they help get them set up, not only to refer them to somebody, but they actually can do that right there in the office and get them connected to coverage right then. So that they're not underinsured, and that way they at least have some form of coverage. They help walk them through not only what plans are available to them, what's the best fit for them and their families, and as well as what will help with the program, cover the program expenses as well.
As far as you know, does the typical, just say Primera plan cover this sort of treatment?
And a broad statement will say yes.
Okay. All right. Very good. Any other questions? Derek?
Oh, I was just going to say, I think the grant that you're talking about, that flows through the county's community behavioral health services, right? And I don't know if that's state or federal money, but it comes in and it's kind of like a gap filler, but you only have so much to use. And so I think your financial patient representatives, they have to gauge how much of that grant they can give to different folks to fill a gap, because there's multiple people that could potentially use some of that assistance, right?
Yeah.
Okay. I think that was one of the funding sources that was on our federal agenda that we wanted to keep funded from SAMHSA, but I could be wrong.
Thank you.
Derek?
I was just going to say 92.5% increase over the year. That seemed to be pretty awesome. Is there something your team did differently?
I don't I think really that our clinical assistants just really pushed for that. They kept trying, and sometimes people come in, they're busy, they don't want to do it, but they just kept at it and
Okay.
got more.
Because I think the more data you have, the better that you can.
Absolutely. We did
And so-
extend it for the first month we put it out. We didn't get a large return, so we put it out another month and
That's great.
continued to push.
Okay. Thank you very much.
So I actually want to address one other piece in regards to, Patricia, what you had asked in regards to coverage and the gaps. And because our staff do, as April had discussed, they work really diligently on trying to ensure that all of our patients and potential patients that come in to see us are covered and do have that. And to your point of the gap, one of the biggest things that we've started seeing is that when individuals do become employed, they don't meet the criteria. They just go past that cutoff point for eligibility. And then if they do have insurance coverage, sometimes their premiums are really high, but then their copays or deductibles are significant as well. So then that's one of those barriers that we're really limited on what we can do other than finding resources. But we do, when we find them, we do offer them. There was one here locally within our community year before last that was available, and we were able to utilize and help several patients as well.
I'm assuming it's a small number of people, but is that an incorrect assumption?
It varies, honestly. It can be just a couple, 2 or 3, or it can be upwards of a dozen or more. And the stories that we hear from those individuals are truly heartbreaking. And people are literally choosing whether or not to maintain their program and their recovery, or do they pay their rent? Do they take care of all these other requirements and necessities of life that they have?
Yeah, I just wonder if there's something that we can do more than what we're doing now to try to figure that out.
I'm open to suggestion.
Yeah. Okay, well,
I just wanted to
top of
address
mind.
that.
Yeah, thank you for answering.
Okay, so this is the same slide that is updated each month, but wanted to give you a moment, and it's updated. We did take a couple of pieces and readjust into a couple of other different slides this time around, just so that we could delve into them a little bit more detailed. To start with, so one of the questions that was posed was the reasons for potential discharge of our patient population. And with that, Adam and I asked him to pull some of that data. And the number one reason that we have on record for our patients when they leave our program is unknown. Honestly, they leave without communication, or they transfer. If they transfer to another facility, we have that option to identify it as they're transferred. However, more often than not, we just don't hear from them, whether they just stopped coming to the program, they've relapsed, they've gone to another facility to do some other type of treatment. If we know that they're incarcerated, that's captured here as well. And you'll see that the blue is January, the green is February. And then alongside of that is our assessments, and I'm going to kind of jump on this one real quick. This is the expansion timeframe. So since we have done our expansion on February 21st, these are our numbers for assessments and discharges by week, from week 9 through week 12. And the orange is discharge and the blue is the assessment. So I know the discharge reasonings were a conversation that we've had previously, but really to call that back out, that these are the reasons that we actually have to input into our data systems. And so this is the information that we're able to capture if we are able to get it from the individuals. And then the next slide, like I said, is as we've started, there's more details on the assessments and discharges regarding expansion as well.
So the expansion happened on February 21st. So it's been just about a month. But
Correct.
what does this data actually capture? Like 3 weeks of that month?
Through the end of last week. Correct.
Well, this one, it is through the end of last week. And because SRHD starts its weeks on Saturday, that's basically became like the starting, and that's why it only is week 9. We have the next slide will show you all that goes all the way back through the beginning of the year, but this particular one is purely expansion, assessment and discharge.
Yeah. It does not reflect the entirety of the program assessments and discharges. It's specifically just during that time frame.
Right. I guess I'm just saying I don't know if it tells us a lot yet in 1 month. I don't know if
No.
it really gives us any real data, but I appreciate
It's
it.
a starting point. It
Yes.
definitely gives us those starting points.
Yes. Yeah. It'll be interesting over the course of the year to see how it changes.
Correct.
Maybe you said this and I didn't hear it, but what does lost to contact mean?
It's exactly that. We lost contact. They didn't have any contact with us and they just walked away.
Okay.
We've made efforts to reach out to them and they're just not communicating back. So going back into assessments and discharges. So the data on the left is broken out week by week. And this gives you more of a detailed, granular look at our assessments and discharges. So that first page that you get each time, every month, shows you that, yes, there are assessments, there are discharges. This actually breaks it out and shows you that every week we are providing assessments. We are doing intakes. We are doing discharges. And so that number of our total patient census is not just static. It doesn't just kind of stay at one spot and go up or down a little. There's a constant ebb and flow internally, but the total census number may be a minor fluctuation up or down. So this just gives you the week by week visual on that. Additionally, it's just the bar graph that goes along with that, just as a different visual representation. Okay. Excuse me. So we're going to get into, this is visits by hour initially. So that first 2 bars are 5 to 8 a.m. The second 2 are 9 to 12. And then that smaller one is that transition hour of about 1 o'clock. And then the expansion of 2 to 5, essentially. Now, all of the green are the patients coming in prior to the expansion timeframe. The blue is patient numbers during those timeframes since expansion. So yeah, we did see a slight decrease during those morning hours. We saw an uptick in the later morning, and the expansion we didn't have any starting points until now. And then additionally, we have the visit types after 2:30 on weekdays and Saturdays. And I know some of the notations are a little more difficult to read, but essentially these are the appointment types or the documentation notes that are happening, meaning whether the individuals are meeting with staff for bus passes, a dose eval, a health history, an intake, whatever the case may be, that's what these are. And the orange is representative of Saturdays. So those are the appointments and the documentation that's happening on Saturdays. The blue is the entirety of the expansion timeframe. I know there's a lot of different pieces on there.
It looks like they're coming on Saturday.
Yes.
Which is good.
Yes. Excuse me. So one of the things that I had spoke with Adam about and I had requested was missed dosing was something that was a concern that we were interested in seeing where those numbers fell from prior to expansion to now. And what this shows is on Fridays, we had a pretty consistent number of individuals that would miss coming in for their medication. But then they would come in on Saturdays. So what this graph is showing is that number of Friday missed doses is actually increased, whereas the Saturday decreased. And the reason for that would be that we're actually open and accessible longer timeframes on Saturdays. So if an individual doesn't have their lockbox for the weekend, they know that they can come back in on Saturday for a longer period of time. So that gives the opportunity for, again, that accessibility. So to your point, Patricia, yes, that Saturday they're utilizing it, and it's actually decreased the no-shows for the Saturday reports. Okay, and again, this is all in relation to expansion. Patients, this is, the green is before, blue is after expansion by hour. And I'm not gonna go line by line, obviously, but it just gives you a good visual representation. Before expansion, it was pretty consistent throughout the morning, but what we've noticed is that we have a slower, or not a slower, but a handful less in the 5 o'clock hour, but not many. But it actually gradually tapers down the rest of the day. So it is being utilized throughout the day. It does, that last hour does get very slim as far as the number of individuals coming in, but it's still being utilized. Anything else?
So when you're looking at these numbers, obviously it'll take like probably 2 or 3 months to even see any patterns. But how is this influencing like your staffing and things that you're thinking about operationally? Like you used to have you had a lot of people dosing very early in the morning.
We still do.
Right, but I mean, it may start to, new patterns might emerge, and I
Right.
suppose that would create maybe different staffing needs throughout the day.
Right. And Adam and I meet weekly, at least, if not 3 to 4 times a week. And we do review and look at these. And as we start to see some of those things, that's when we'll start to address them. Because unfortunately, everything is so unknown. If we start to plan and prepare for each scenario, we're going to be going in circles. But we have thought of some of those pieces of what would that look like? What could that look like? Start opening later is not something we want to even explore.
Oh, no,
at
no,
all.
no. Yeah,
Right.
I'm just
But
saying,
staffing-wise,
I'm hoping
yes.
you're using the data to think through those things. And
Absolutely.
then also Saturdays. I mean, if Saturday gets really busy, you might have to up staffing on Saturday.
Absolutely.
Yeah.
It would just be looking at what we can do with what we have currently within our staffing, within our structure, within our hours, all of those pieces, and looking at it as a whole for all the positions in order to ensure that every part of the patient care is accessible. Okay. So with that, actually going directly into what are we going to be doing and what are we doing? Wendy Brizendine is going to come up, and she is our community relations coordinator, and she's going to show you some of the plans moving forward to ensure continuity of communication and community partnership.
Hi, good afternoon. As Missy said, I am the community relations coordinator for our treatment services program. And I have been working with Misty and our management team and our communications team. When we first rolled out the expansion, we worked with our communications team and we got the word out there through our news sources, through social media. But we said, what more can we do? Because we need to be known. So we put our heads together and this is what we came up with. Right now, one of our biggest barriers is not the quality of care. It's the awareness and the access. People can't use our services if they don't know we exist or they don't understand us, especially in the population we serve. Some battle housing instability, crisis, and all of them battle stigma. We have to meet individuals where they are and not wait for them to find us. That's what we prepared here. What you're seeing is going to be a coordinated outreach plan, not just marketing. And what we have done, this approach is designed to increase admits, reduce drop-offs, and improve the continuation of care. Because without individuals and how they understand how to engage with us, before they ever walk through our doors, they're more likely to seek us out. So what we've done so far is we've tried to involve ourselves more with the community. It's something we've always done, but it's something we're pushing more towards. We've assigned ourselves more in tabling and participating in community events. We've increased our participation and visits to community partners, not only with myself as the community relations coordinator, but we have also brought on a jail intake counselor and a community counselor that is also in the community out there reaching out. Along with that, we have had partner site visits. We have brought in many of our partners out in the community, and they educate and talk with our staff to educate them on their programs and how they can help our patients. So our counselors can refer our patients out to care that we cannot offer them. Along with that, we have started putting together a partner media kit. What we've put together here is a media kit to leave with our community partners. This will include stacks of these papers that they can pass out to their clients if they'd like, if they're interested. It'll include posters, flyers, takeaways, brochures, along with, as we spoke earlier, the one down here on the bottom, kind of in the middle, is our insurances that we worked with our finance. It lists all the insurances we currently take so our patients can know that ahead of the time. So we've been working on getting out there all the information we can so patients know ahead of time what we can offer and what we can work with so that we can work with them. We also added a QR code to all of our pieces for easy accessibility for our treatment services homepage. This goes directly to our homepage so anyone can find all our contact information easily and quickly. We've also put together an email list of community partners, and we have started sending out emails with program updates, news, etc., so we can better collaborate with our community partners, and we can reduce barriers so that we can work together and offer all of our community the best care possible by working together. Also working with comms, we're going to increase our social media awareness for treatment services by posting once to twice a week. We're also going to start adding hashtags to our social media for treatment services. So not only does that make us more trackable, traceable, it'll also increase our awareness online. So through doing all this is what we're hoping to do. We're going to bring this out to the community. We're going to deliver it to partners. We're hoping to do this to be more seen. This approach was put together by our team with our clients in mind. It's not just for the sake of visibility, and it's not just for numbers. It's about removing barriers to treatment and making sure that when someone is ready, we're impossible to miss. Thank you.
Thank you very much. Really appreciate that, and appreciate the enthusiasm behind it as well. It's great. We'll get the word out really well. Any questions on the
I just wanted to say I think this is great, and I appreciate what you're saying about meeting people where they're at. I would guess that clients come from all walks of life and all different income backgrounds. You know, there's folks that are housing, you know, unstable like you described, and so there's a lot of social service organizations, right, that work with those individuals that can promote your services and help you connect people to your services. How are you thinking about folks that are struggling with their substance use disorder? They may have a job, they may have a home, but they need your services. How would you connect with I'm thinking of more maybe traditional other healthcare partners where they may be going, their primary care doctor, their you know, how do you promote that you're a safe, accessible place to people who you know, are out there working, housed, but need your services? They may be afraid, right, to talk to their doctor about their disorder.
Sure. I think that a lot of that falls on my job, and it's something I've been trying to do as being community relations. I have been working and touching base with places like Chaz, clinics, trying to get our flyers in there as well, so that say someone that is maybe not as homeless or whatever, or has a more stable lifestyle can still find us and feel safe coming to us. That is a little bit of a different category of person, especially because with the stigma, a lot of individuals don't like coming forward. It could affect their job, it could affect their lifestyle. So they do like to keep that a little more secret. I've also put flyers in a lot of places in our community that you wouldn't think of, such as laundromats, pharmacies, places like that. Uplifting photos, not just, photos that show, that are engaging and welcoming and warm, that say that we're available so that any individual will feel comfortable approaching us. That's my goal here, is to be more seen by every individual, not just basically the individuals we're seeking out to help. So that maybe that grandma can take a flyer to a grandchild that may be struggling, or another individual that they thought might need help. So we can pass the word. The other biggest is, our biggest way to get out there is word of mouth. When our clients enjoy our services and they feel comfortable where they're at, that word of mouth is our biggest support. It gets around and it spreads like wildfire. And as our voice of the customer showed, I like to think that our patients are mostly happy where they're at, that our staff really cares and it shows, and that there's a passion behind it. As you said, I've found a passion since I've started working with this team in this program. That can't be missed. Everyone in that building, you walk into treatment services and you feel it from every employee. There's a passion there to help people. Everyone wants to be there. And I think the patients feel that and they spread it. So hopefully by getting all of this out more in all the community partners, all the places, the laundromats, the pharmacies, that we'll just be more visible, and that'll make people more comfortable to seek us out.
Yeah, I was just thinking our businesses in the community, restaurant businesses, other businesses, I know that they want people to be helped. I know they want people to thrive. So, I think this is great, because once you have this kit, it can be accessible to all sorts of different, from healthcare partners to businesses in the community that can put a bump in their restrooms or in their businesses, that, just, on bulletin boards everywhere, so that folks, when they're walking in, they see it and maybe they write down the number or, take a picture of it.
I put one in my Rosar's pharmacy like a year and a half ago, and they have yet to take it down. So when you walk into Rosar's, it's right there in the bulletin board, and I love that they haven't taken it down yet. I'm always ready to put another one up, but so.
You said you have an email list of community partners, and I'm just wondering, are you tracking, who opens those emails, or if they read the material that you send? It seems like it would be a good way to know whether you're actually reaching your targets, and that there might be another workaround if you're not reaching them that way.
Yes, I am tracking it, although it is fairly new. It's just something we started. I got most of my contacts at the Homeless Connect this year by collecting every business card I could get. So this email list did just start, but I am tracking it, and I'm adding people as I go out in the community and get more contacts. So I'm hoping it will grow, but yes, I am hoping to track and get info from that.
Yeah, I just want to say I'm really excited about this. I think this is what we had talked about, last year when we were talking about expansion of the service to provide more access to people, and knowing that this is an area that, there is still a stigma. There is all this embarrassment about it. And I really like this approach. It seems very accessible, and also the social media aspect of it. I think there's a lot of people that actually probably are going to hear about it, not just from word of mouth, but on social media. And so how to maybe you're skilled at this. I know that there's a whole science behind marketing on social media. So I don't know if there are other ways that we can utilize that method, and potentially keep track, like to Patricia's point about where we're getting the response from, and if there is on social media, if you can hear like clicks or
Yes.
any of that, that's that then we can target even further, utilizing social media even more.
Yes, I am working with the communications team to do that. I found that in a district, we have so many divisions that the communications team is promoting on our Facebook that it can get very easy for us to disappear. We're one of several divisions being promoted. So I am working very closely with the comms team. That's why we're adding the hashtags to individualize us, and it will help us make it easier to track us. You can put that hashtag, SRHD treatment services, and it will bring up every every post that we've ever done. It'll help track, and then the comms should be able to see that on the back end of Facebook, how many clicks we're getting, how many engagements, how many clicks led to our webpage. So we should be able to get all that kind of data. So.
Commissioner Kearns.
With the media kit here and the promotional material, you'd reference like kind of tabling at different events and different community events. What are some of those events, and have you started? I noticed what one of the photos looks like you've done it at least one event here.
Yes.
What are some of the other events you've been at, and what events do you hope to be at in the future?
I've also been working with the health equity team. I reached out to them and asked for a list of all the events they've been attending this year. They're really great about communicating with the district as a whole and asking anyone that wants to attend certain events. So I've got a list, and I reach out to my team and ask who wants to go with me. The event we went to on this one was Homeless Connect. We've been there a couple years in a row. It's a huge, amazing event. We've also done Helping Hands that was put on by Amanda Duggar here at the SRHD. It was a great event last year at the library that we had that I was lucky enough to help her with and be a part of. We've also done was it Speak Out Loud or the SAFE event at Riverfront Park a couple years. And among a couple others. And then I do know that the health equity team, whenever they go out and table anywhere, they always take some of our stuff for us if we're not able to be there. So the district really helps us get out there when we're not able to be there as well. So yeah, of course.
To Commissioner Waldrop's point, if you're not working with Big Table, I'd love to introduce you guys, because I think that'd be a great partnership for the working class that isn't necessarily seeing this at those events.
We would love that. We've also done community education. Misty has gone out with me a couple times. We've educated the bus garage in Deer Park. We've done a family safety night in the Deer Park area, among another couple nights where we talked about medication safety, and stuff like that. So anything we can do to get out there to educate our community, we are all about. So anything you can throw our way, we would love to do. So.
Not seeing anything else. Thank you very much for the presentation.
Thank you for your time.
Absolutely. And then next up, we have a tuberculosis presentation. Mark Springer.
Thanks everyone for having me back here for talking about TB again. Are you driving the slides, Ann? Or is it just me? Okay, let's try that. So, this is probably about 6 months since we had a chance to talk with Board of Health earlier with our TB update in the fall. So we wanted to give you a little bit of update of what's happening in the program. And I know we have some new board members, so we want to provide some education in terms of the basics of TB, as that's a significant public health service that we have here. So, what I wanted to kind of really stress on this introduction, with this first slide is with TB, we have two things that we're talking about. We have TB disease, which is an active infection. This is a person who's symptomatic and there's a risk of communicating the TB to other people when people have TB disease. And our numbers for that in our county are very low. But when we look at the other side of things, when we call a TB infection or latent TB infection or LTBI, what we're talking about in that circumstance is people who have a TB infection, but it's latent. It's, they're like a carrier. They're not infectious to other people. They're not especially sick. It's a silent disease at this point. But the numbers are much higher. If we look at this, with the US, the numbers here, approximately 13 million people have LTBI, and a certain proportion of those people are going to convert to TB disease every year. And that's why we are kept, so busy with our TB program. TB is also a challenging disease to manage because of some of these different factors. It's a rare disease for someone to have TB disease in the community. So providers don't necessarily see it all the time. They may not be thinking about it. in primary care and when someone initially presents symptoms of this, it may not be the first thing that comes to mind. And so what we see oftentimes is delays in diagnosis because of this. It also impacts populations that typically have poorer access. I mean, oftentimes these are people who are born overseas, maybe people who have a distrust of the medical system, maybe people who are unhoused and don't have a primary care provider, don't have insurance, speak a different language other than English. So there's a lot of challenges with engaging those people in healthcare. The other couple of things that make TB management a challenge is it's a complicated treatment program. When we're treating people for TB, they're on treatment for 6 to 12 months. And that's very, very challenging for anyone to stay engaged and compliant in care. We have to make sure that they're taking their medication at the right cadence. They're not dropping off, because if they do drop off from care, we have a lot of challenges in the sense of that person could become symptomatic again and ill. They could be infectious to other people once again. And then there's the danger of drug resistance, where they could become resistant to some of the more common medications for TB, and that creates its own additional challenges of longer treatment duration and more expense when we're treating that. So with public health, TB is one of the diseases that public health really has the major stake in terms of management of TB disease. We do consult with infectious disease at times, but these patients are not really easily managed in a typical care setting because of the long duration of treatment, because we have to just observe treatment to assure that a person is getting treated. That's the major part of what we do, is that the treatment of TB patients. We do also have a case investigation function where we're investigating each new case and looking at their household, looking at their work to try to identify if there's any transmission that may have occurred within their circle of acquaintances or family, or their network at work. Then we have some component of our work that's supportive in terms of while we don't provide primary care to these patients, a lot of times we're in a little bit of the position of being a social worker, in the sense of we're coordinating their care with other providers and making sure that their other medical conditions aren't interfering with their TB treatment and vice versa. So this is a little bit of a snapshot in terms of kind of the impact of TB with our program. I kind of framed this in terms of deaths, but you can also see the case counts there. Our case counts have been pretty steady over the last several years, and this is what's led to an expansion within our program. But I want to call attention to kind of first quarter for 2026. We've already had 6 cases of TB disease that have been reported to us as of this year. So we're still, seeing an upward trend, in terms of TB. And, this is still kind of an issue that, we're trying to address, from a staffing perspective and from the perspective of the changes being made in our division and in our programs. So again, looking at the work of the TB program, we're treating people with TB disease. We're conducting case investigations. We're putting people in isolation during the initial part of their treatment if they're infectious at the time that they're referred to us. We're kind of managing LTBI infections when those are appropriate, because what we've seen in the past is if someone has a new acquisition of TB infection, they're newly acquired their LTBI, probably from a family member or from a case, that they're in close contact with, they're at a much higher risk of moving to TB disease. So we've had cases in the past where cases either didn't want to get started on LTBI treatment at the time when they were identified, and then within a year or two have become cases of TB disease that we had to manage at that point. So from our perspective, it's more efficient, especially if they're in the same household, that we kind of coordinate the care of LTBI cases as well. We also coordinate kind of refugee screening, that happens with Unify, and they do some of the work there, but we help with coordinating that. We do some education with healthcare providers around TB disease and diagnosis and treatment. Our hope is that we can work with providers in our community to do more LTBI treatment, because that's a way that we can get ahead of this and treat many of these people, hopefully before they move on to develop TB disease. And then we have a little screening internally. So our current staffing model is we have 2 nurses, a community health worker, and we've been approved for a 3rd nurse with the approval of the budget last year. We're still in the process of hiring for that. It's a tight job market for nurses, in Spokane. So that's been a little bit of a challenge. But we also have used disease investigation specialists to support our TB program during that time, because those high numbers are really challenging to work with, especially when you think about each of those people with TB disease. Our nurses are going 5 days a week, to that patient's home in most cases. So one patient is 5 visits, during the week. So, and with our numbers being as high as they are, it becomes a little challenging. And so we've brought in one of our DIS to help support the team by providing DOT for cases that are uncomplicated and that are already enrolled in treatment. We have, some challenges in terms of cross coverage and vacation coverage right now until we can get our new nurse on board or be able to hire that person. So this is kind of looking at our workload, and I'm framing this from the perspective of workload rather than our case counts. So what you see for any given month, this is the number of individuals that are being managed for TB disease. In orange, the green is people who have LTBI and are being treated by our program, and the blue are contacts that are being investigated. And I put a little bit of a marker there for the last several months with Eastern State Hospital. They've had, one of our cases was an employee with Eastern State Hospital last year that led to a large contact investigation. And so I want to really frame this as our workload over here. And in many of the cases, and employees that were tested and screened with Eastern State Hospital were being managed by Eastern State Hospital. We managed a component of those, but in terms of looking at the data, it's very hard to disentangle what's our workload as opposed to our data management, for our cases as a whole. That contact burden in terms of the investigation for staff and residents in the Eastern State Hospital was well over 300. So a significant burden in terms of time. So this is our current situation. We're still in the process of hiring for our TB nurse. As Dr. Velasquez mentioned, we have made some reorganization efforts within our division, moving from 4 managers to 3. And one of the advantages to consolidating our TB program with some of our other services downstairs is it provides us some opportunities to gain some efficiencies. As one example, if our TB nurses are out in the field doing DOT, they can't be at the health district doing screening of a contact that's coming to us to finish up their contact investigation, testing. But we do have staff on the first floor who do testing and can do blood draws, and that becomes a way for us to kind of gain some efficiencies over time where all of our clinical and direct services are in one program. So we're hoping for some additional efficiencies with that over time. So I don't see Brian. Oh, there he is. There's Brian Wan is our new program manager for our first floor program, including HIV, STIs, TB, and our syringe services program. So he's our new leader in that area, and we're looking forward to some really good things happening with the program with that transition. And I think kind of just moving forward just on some budget considerations. Just as a review, this is kind of where our funding comes from for TB. It's primarily funded through the Spokane County. And there are some other revenue sources that we see from FPHS. The Washington Department of Health grant that we get is pass-through funding from CDC. And then we have some other funding through Medicaid match that allows us to bring in some other funding to support the program. And this is our budget from 2025, looking at our expenses. And you can see a fair amount of red there, with that. We had an increased number of cases. Some of these cases were quite complicated. And because of the high case numbers, we've had a significant burden of overtime, for our nurses, because unfortunately, when something happens, it happens. We get a new case. We had someone on leave, earlier in, I think, February. And right when someone was on leave, we got a couple new cases that came in at that time. And so that becomes a challenge. We're hoping with having a third nurse that we're going to be in a position that's more stable, that staffing model can also be supported by a DIS who can move to support that program on an as-needed basis, for some of the less complicated cases with DOT. And we're hoping things with a few more efficiencies that can help support us on that.
Mark?
Yes.
Question just about funding stuff. So is there, are we not able to bill like Medicaid or insurances for the care, the TB care that we provide?
That is something that some LHJs have been able to do a little bit. There's some nominal billing that you can do for DOT. I think the challenge that we have had historically is our numbers have been small enough where the cost of having a billing specialist or someone who would be doing that would just outweigh the reimbursement for that. But we're reaching a point certainly where we want to be conscious of trying to save money in any area with that.
Yeah, I was just wondering if there was some ability. We already have billers for
With
our
treatment
OTP,
services, yeah.
So is there some program, where we could do some of that?
I think that's an area that we are looking at actively right now.
Awesome.
Yeah. At this point, I mean, we have, some kind of fixed costs. These are the primary costs that come about with our TB care in terms of just diagnostic costs with quantiference, which is the blood test that we use to diagnose TB, and then really imaging to document progress in terms of progression. We have some other costs that are associated with TB, and I kind of lump these between compliance and incentives. So for compliance costs, these are things that make it doable for a patient to complete their TB treatment program. Some of that is they may need transportation assistance to a provider, that's managing some of their chronic medical conditions that may impact their TB management. Sometimes it's someone who's doesn't have a cell phone, and we need to be able to reach them on a routine basis and schedule DOT visits. So during those periods of time, we might provide them with a cell phone. Sometimes it's isolation expenses where we have someone who's infectious and we need to remove them from the household, while they're infectious, so that we minimize the risk of transmission, within the household. Then we have some things that are incentives, that are geared to getting compliance with what we want to have happen. And some of these are a small gift card for someone who's a contact, we need them to come in for, their quantiferons, they need to come in for the 2 blood tests, and if they're positive for those, that we need to get them a chest X-ray. And so we do utilize those to improve compliance, because one of the things that we see is, the people that we miss are, for a small nominal cost for, an incentive, are the people who potentially could turn out to be a TB case down the road and have significant impacts on the program on that. So that's a little bit of an overview of the TB program. But I want to open this up for questions and see if there's anything that I can answer for all of you.
Any questions?
Can I make a comment before?
Yeah.
So thank you, Mark. I wanted to clarify, when you look at the 2026, those 6 cases are new cases. The actual volume of patients that are being managed right now is 14. Because remember, it's long-term treatment, so they don't necessarily finish in the calendar year. Otherwise, it looks a little bit skewed. And when he talked about the high volume, it's about 14 patients that we're actively treating right now, as he described. So 6 are new ones, which is a really high number for just 1 quarter. But if that continues, that 14 is going to be blown out of the water in the next few months. So I just wanted to mention that.
Are there others that we're monitoring as well that may not have an infection yet? But
So we monitor, we also treat latent infection or latent TB, which is a handful of those, and we also have a number of active ones. And what we have noticed over particularly the last 18 months or so is the complexity of the cases that are coming to us has increased dramatically. They typically have multiple comorbidities. And although we don't provide the care for their diabetes, heart disease, renal disease, if their diabetes, heart disease, renal disease are not under control, our treatment is not going to be successful. So we're basically case managing for complex diseases. Because I think probably about 60% of the cases we have actively in treatment right now are all complex cases. And that's just something has increased dramatically over the last 18, 20 months or so. And given the new cases that we have received a notice of, that trend doesn't seem to be changing. So that makes it a little more complicated, because that means that we need to coordinate with 12 other specialties to make sure their care is being delivered and that the patients are complying. So many times we're the ones ensuring they're complying with their diabetes and cardiovascular disease medication and their renal disease medication. Otherwise, the treatment is not going to be successful. And some of them are, the level of acuity is so high that over the last 6-8 months, we've actually seen lots of patients that have been hospitalized multiple times, which in and of itself, that's another level of complexity, because then we have to make sure that our healthcare partners are protected and so on and so forth. So the complexity just keeps escalating. It's not anymore, I came coughing, lost weight, I have TB. It's like, I'm here and we have 17. Some of our cases are being called medical mysteries by some of our specialists because they have so many issues. So I just want to say thank you to our nurses, because that takes a lot of time to manage that. And legally, these are all my patients. So I do the home visits or they come here. So there's a lot of involvement that may not be visible, but takes a lot of time, a lot of effort.
right.
And to some extent, it's not because we're unlucky in getting complex cases. When we look at those LTBI numbers, you're more likely to convert from LTBI to TB disease if you have diabetes or some of these other conditions. So it's not that we just have the bad luck in terms of getting more complicated cases. It's oftentimes these people are just, as people age, you get more chronic medical conditions, and your likelihood to convert to TB disease increases at that point.
Commissioner Kearns, you had a question?
This could be a difficult thing to answer. I don't know if this is a way that we track this. So it sounds, if someone has the latent TB, it can transform into TBI disease, you said. Someone can catch tuberculosis from another individual. Are we seeing the growth in our region from it transitioning from latent TB to TB, someone who doesn't have TB then catching it from someone, Or are we seeing people coming
I
to
know-
the community
I got your
and they're
question.
already infected with TB, and that's what's growing our numbers?
Good question. Good question. So, you know, I can't put a percentage on it, but I would say that Dr. Velasquez, you can correct me on this, but I would say probably 60 to 70% of our cases are novel. They're not necessarily connected to another TB case, but we do have instances in families where one person has TB, another person has LTBI, and then we have a conversion happening within that household. And if we kind of look at, you know, other exposure settings, we have seen conversions. We do document those conversions, and that's part of the reason why we are so focused on that contact investigation, because if we can catch them at the early stage of the conversion, we know that they have an LTBI infection, then we can treat them before they go on to develop TB disease over the next year or two.
Can I ask, what do you said 60% are novel? What do you mean by that exactly?
So they might be coming to us from the hospital, and they don't have a connection to a current TB case. So they weren't a contact before, they weren't a latent case before in our records. They are just a new case of TB disease.
Okay.
And so in that sense, we don't know necessarily how they got that infection, or if that was many years ago, or what the circumstances are, but we can't connect them to one of our existing cases.
Okay. Thank you.
Yeah. Good question.
Patricia.
I'm just looking back at the incentives part, and this might be a question for Kim, but how is it that we're able to give gift cards for TB treatment benchmarks or for submitting samples? How is that covered if from a financial perspective and not considered giving away public funds?
It has a lot to do with the type of program and kind of what has been best practice and what has worked for us. So we worked with Spokane County to identify what are like eligible, reasonable expense reimbursements so that we can bill against that. So it's not specifically a federal grant. We do have the Department of Health funding piece, and then the foundational public health services piece. We get a little bit of that. So we have some discretion in using, it depends on the funder and the grantor putting those restrictions. So it doesn't fall into gifting of public funds because we're asking them, the client, to perform or comply with X to get Y. So demonstrating like that, you know, 1 month they meet the medication criteria, and then the following month, if you do it, it might increase by $10 or so.
Yeah, that answers my question. I was just thinking about the treatment services before when we were talking about how to pay for different things. And so that totally answers it. Thank you.
It's really specific to the funder and the grantor.
Okay.
Yeah.
Okay. Any other questions? Seeing Derek?
I'm just looking back at this case, the program caseload. And you have about 4 months of contacts that are really high. Was there a reason? Was there an...
So a contact investigation usually takes about 2 months. You know, we have to, we test them at the beginning when we identify them, and then we test them, you know, about 10 weeks later. And at that point, if they're negative after those 2 times and their person in their household is no longer infectious, then we can kind of rule them out for acquiring TB. So usually what happens on these is we get a contact investigation. If it's a family or a household, it might be 10 or 15 individuals. And that seems high for a family, but if you have kind of extended family, people, you know, we have sometimes people who are, you know, moving between multiple homes, you have split families and things like that, then we have a large number of people to investigate. But then we have, you know, some instances where it's just this person might have 1 or 2 people. There's no kids associated with that. And so the numbers are, you know, they vary quite a bit, you know, on that.
Okay, so then does that mean that they would stay on month after month?
So while
in
they're being
case.
monitored, we are counting them on that graph.
Okay.
Yeah, while we
Okay.
are working, because there's some scheduling with them in terms of the testing. It's not the same cadence as we look at for LTBI treatment or DOT, which is daily, but we do have to be in contact with those people and kind of manage, kind of their testing as well as any x-rays if those are needed.
Okay, thank you.
Yeah.
All right. Thank you. I'm not seeing anything else. So thank you very much for the presentation.
Thank you.
Appreciate it. And I guess we're going to turn it over to Kelly for the National Public Health Week. Ready, set, action.
Does this move it? Oh yeah, there we go. Ready, set, action. So National Public Health Week is coming up. So we'll end today's meeting on a positive note, but also want to impress upon you the importance of National Public Health Week. This is the one time of year where we as a health district can really proactively go out there and talk about the positive things that we're doing for our community. And as you can see, our Ready, Set, Action, we actually own it. Every year we come up here and present to you guys and present to our community about how much we take advantage of this week to get the story out about our employees and the great work that they do. This year, the Ready, Set, Action theme is started by American Public Health Association, and their idea is that it's a moment to recognize how public health has improved our daily lives, safeguarded our families, expanded our lifespans, and strengthened our communities. This week is also a chance to honor the public health workers who show up for us every day and advocate for policies and practices that promote good health for all. Whoops. I feel like I'm missing a slide. Well, I'll just keep going. So there's a slide here that's missing, and it's about staff engagement. So National Public Health Week has always been an opportunity to tell our story, to see the people behind the work that we do. And we may work behind the scenes, but this week we get to be out in front. And so we took the time to meet with each of our programs and ask them, what is your Ready, Set, Action story? Tell us about a time when you really felt good about the work that you did, or when you felt pride from seeing the results of your hard work, or when someone thanked you for safeguarding their health. We saw gratitude for working at SRHD from our staff. We saw passion for helping others. And I won't lie, we saw some tender moments, some kind of somber moments that really make us realize how important the work that we do is. So we'll be compiling these stories, and we picked a few of these stories to share with you and to share with our community. You'll see Jazzy. She's a research scientist. Some of you have seen her up here presenting. She's out in front quite a bit. And she'll tell the story of how important it is to hear from the community and to learn from them when developing our community health needs assessment. And we have staff talk about the importance of working collaboratively when we have to work together. Some work together collaboratively internally and also externally with partners. And we saw that just recently, and we're seeing that today. I'll just side note that the press release did go out about the measles, so you should all be seeing that in your inboxes. But we really saw a great collaboration effort with our healthcare providers when we have measles exposures in our community. And then you'll also hear from Eileen in the community, and she's going to talk about bringing community partners together to form the County Interagency Coordinating Council. And they focus on making services easier for families to access locally and on building community capacity for early intervention services. So look for those, and they'll look a lot like this. There's Jazzy there, and also Kayla. So our messaging will include images of our employees, working to ensure the health and well-being of everyone. Again, Jazzy and Kayla, they're telling their action stories. And you'll see this along with the Ready, Set, Action branding in the Spokesman Review, both print and digital. You'll see that in the Spokane Journal of Business, that week's Inlander, as well as on their digital news websites, mall banners downtown, also in Spokane Valley, And then, of course, our owned media, which is our social media, our blog, our newsletters. We also developed a PSA that we'll be sending out to be shown. And we also have a message going out on Spokane Public Radio. So our goal is with this buy to raise awareness of, instill confidence in, and galvanize the support of work of the Spokane Regional Health District with Spokane County thought leaders, with business owners, and community involved adults. I've shown you this every year because we get really excited when the city lights up as blue. So we work with Downtown Spokane Partnership to make sure that that happens and that Gumby is looking over the health and wellness of our city. And of course, SRHD will participate by lighting up blue during that week. And we get our community involved. So proclamations are set to do with the county commissioners, also with the city of Spokane Valley, and we're working with the city of Spokane as well. So you'll be seeing that, and they're all really great partners at sharing. And we have other partners in the community that share out our messages. We're really grateful for them for doing that, because that's what it's about, is those partnerships and showcasing those. It's about that, and it's also about our staff. So we want to make sure that our staff feel really recognized and that they know that we're grateful for the work that they do. So keeping the focus on them, we'll be holding an internal open house and staying with our theme. Much of our action takes place with our community partners. So we have invited a few of them to come here and talk about their role in public health and how they work with our programs and possibly make new connections with other programs within the agency that they could develop new partnerships with. And it also gives programs an opportunity to see what other programs are doing and maybe enlighten them to do some other. And this is part of our strategic plan too, when you look at that, and it talks about working out in the community and building those collaborations. And this is one way that we can show examples of that to the rest of our agency. So we also have a fun activity this year, and it's a collaborative art project. So that's going to be fun. And then we always have a group of programs that host snacks for the day. And this year it's going to be a bagel bar. So mainly it's our admin teams on the third floor that are all coming together and making sure that we have snacks for this event. And of course, you're all welcome to come. And so I've shared with Anne an invite just today, Anne, so don't feel bad. And so she'll be sending that all out to you to let you know what time that is. And so if you want to swing by and join in that open house and also add your touch to our collaborative art piece, we would really appreciate it. And then of course, I have stickers with our this year's logo. I always have one for you, so you can add them to your collection. Do you guys have any questions?
Anything from anybody? Not seeing anything. Thank you.
I just also, please share our posts on your personal pages, share stories about how public health has been a part of your lives. You know, just a small example of breathing fresh air in the morning, or getting a clean glass of water in the morning, or walking on a sidewalk that has a little ramp on it in the morning, things like that. Where has public health, wearing your seatbelt in your car, you really come to realize how much we touch on people's lives. Thank you.
Okay. Well, thank you so much. And I assume we don't have anybody who has signed up for the final option. Okay. And so is there anything that any board member would like to share? Updates? Yes.
I have something. I just wanted to mention that I met with Samantha Hennessy and Callie Morris, who are staff people here, on the dementia-friendly business certification that they are working on with aging and long-term care. And it was a great meeting. And so they're trying to implement a system of putting decals on businesses that AltQ trains these people, trains the businesses how to be a dementia-friendly business. And so I just want to put it out there that if anybody knows any great businesses that are interested in that, please send those people to Samantha, and maybe we can get that rolling.
Okay. Anything from anybody else? Seeing none. All right. Well, we will call this meeting adjourned, and I know our next official board meeting is April 30. So unless something comes up between now and then, we'll see everybody back on April 30.